Thank you. So we will see some of the intraoperative problems as when you are creating your donor tissue. We prefer the older tissue, of course, because unscrolling will be easy, but sometimes you can end up with tears, what Dr. Basak already told. But as he mentioned that even if there is a small tear, it's okay, but you remove the tag and you can go ahead with inserting it. Even 80% of the original what you planned, if the graft is there, it's you can go ahead and do the procedure. And the recipient preparation, if you can do it under air, then it will be good, because the air interface will give you very clear view of the margins, because Dmek is a very little unforgiving procedure than DSEC, so you cannot leave behind small tags in between, so you have to remove. If you are not able to do it under air, then at the end remove the visco and put an air bubble and make sure that your margins are clear and not much of tags. And coming to the donor insertion, and here already they have shown this many times, but here you can see it, you need not, if you are not paying attention, because the beginning we will be concerned with many other things, and even before entering only the tissue has come out. So this we have to keep in mind while engaging the inserter into the wound, and then of course many times we can even again retrieve the tissue and use it. And this is again another what Dr. Fogla and others were showed, that you have to depressurize the chamber before, and if the wound size is also not correct, even before you take out the inserter, the tissue flew out. Though again we have to, we can retrieve. In both cases the surgeons were able to retrieve, and luckily this was the happy ending in the second case. And coming to poor visualization, sometimes we'll end up with this in a very edematous cornea, and also if you manipulate too much, the donor tissue will lose its color. Then again there will be very difficult, it will be very difficult to assess the orientation, your marking and other things. You can debride the epithelium beforehand only, and even you can apply a drop of glycerin before manipulating, and that will clear the view a little bit. And also you can use like from our retina colleagues, we can borrow and use some intraoperative lighting also. And this is one such case where you can hardly see the triangular the tissue there with such edematous tissue. And if you see the unless you pay attention, when the surgeon try to give the pressure in the center to unfold it, that's it, the tissue is gone. So it has gone behind the pupil, and then finally he could retrieve it, it seems, and he was able to use it also. But it can happen when the view is not very clear, like easily we can miss out the thing. And coming to the unscrolling, Dr. Fogla already mentioned, and I use this, the regular cannula itself, I inserted into the scroll in inner core, and then with a burst of fluid, I opened it, and since I know the stromal side is up, I even use it to unfurl it a little bit, and that's how I manage a tight scroll. And another area is where, like, because it's a origami tissue, donor tissue, and it's a very large one, if you can see. It's going up to the limbus. Such cases, you can get that what Dr. Namrata showed as the DM fold in the center. The surgeon is not at all happy, try to iron it out, and then finally, even when trying to inject the air, he was not able to even insert the cannula into the side port, because it's going up to the thing. So he has to insert it through the main wound. And so when you are planning your the button size also, it's very important. Do not be like, you want to put as much endothelium into the eye, so don't go for a very large graft. Okay, sorry. So the sticky tissue already mentioned, there are some steps, iridectomy or your main wound, there will be a lot of bleeding. So wait patiently till it stops, and then go in and do the injection and other things, otherwise it can go and stick. And the same way, remove all the viscoelastic before inserting the donor tissue into the thing. And this again already mentioned, this inverted triangle or V shape. And again here, even with all the precaution, even in experienced hands, sometimes you may end up with a inverted S. Then as they mentioned already, reform again and flip it inside the thing, and then you can go ahead. And this what Dr. Fogla mentioned, the inferior notch or some notch at the periphery, because with this we can move, do away with even the marking. It seems this is recently presented even in the recent World Cornea Congress. And the decentered graft again, not like DSEC, no, we can't just tap it and bring it to the center. Again, you have to deflate and again float the graft again, and then gradually you have to bring it to the center. So this also we have to keep in mind. We can, don't try to just tap it like as in DSEC. And surprise is nowadays I am very unhappy with doing a PI, and especially if you are a messy surgeon like me with a big large PI, then you may end up like this when you are injecting air. At the end of the thing only it went into the posterior chamber. So again I have to search for the bubble, then I saw that it is sitting behind the iris, and through the PA itself I have to remove it, and then I have to replace it again. So it's better, if possible, to do away with the PA or do a very small PA, elegant PA. The postoperative complications, pupillary block glaucoma can occur, and if you leave behind especially a very large air bubble, and at the end of the surgery try to release it a little bit and then do the shift the patient later. And the donor tissue dislocation is very common, more than in DSEC, and here first thing you have to do is doing AIOS2025 and look for the correct orientation. If it is not there, then it may be the reversed graft, and you have to go on again address it. And the first week is also very crucial. It's need not be dislocated only in the first day. As Dr. Namrata mentioned, actually the first day with the air bubble it may appear a little better, and later after the second or third day it may become more and more edematous, more hazy. Then you have to keep on doing AIOS2025 to make sure that it is well attached, or even if there is a slight detachment, better to go and rebubble it. And doing a small graft is easier to maneuver, but at the periphery you can leave behind some edematous cornea, so which can lead on to persistent of bullae, and the patient may not be very happy about that, and they may complain still about the irritation and others due to the bullae, and that we have to address again later. And the primary graft failure, of course, in the initial period it is very common due to our manipulations, and the later stage when you are moving on to doing complicated cases, again you may end up with the primary failure in some of these cases because of difficult maneuver. And the graft rejection is very, very less in DSEC, but still it can occur. The main challenge is to recognize that, because not much of stroma, original the donor stroma here. So early fresh KPs or pigments on the endothelium, immediately be aware of it, and then or some cells in the anterior chamber, immediately treat it as a graft rejection, early rejection, and don't wait for the stroma to become edematous. And graft infection is a major problem in EK in Western countries, where they use the prepared and preloaded tissues. For us it's relatively less because we do it by ourselves as fresh tissue, but still we have to keep it in mind if there is any doubt, because this can be a really a disastrous outcome. And in conclusion, it's a very elegant surgery, as already convinced, you might have convinced by my previous speakers, but still we can go for, we can end up with some small problems, and most of it because we are not paying attention to the minor details. That's what I understood, because Dmek as such is not a very challenging procedure once you know the trick how to do it properly. Thank you.